me.
No. Okay.
Okay, you people are live.
Okay, so today's topic of discussion is compression sutures in PPH. Last class we discussed on the uterine devascularization. As we all know, like atonic PPH is one of the life-threatening complications, and it is one of the major contributor for maternal mortality. And the golden hour is extremely important, wherein timely action, if taken, can save the life of the mother and also can prevent majority of the morbidities which can happen. So today we are going to look at the options apart from devascularization, where some people are quite comfortable with the compression sutures. So today's class will be more about the practical aspects of the compression sutures, and we will just go and see the demonstration first, and then I will show it on the model of the uterus which I have got now, or I'll show you the demonstration on the model and then we can go ahead. So the compression sutures work just by compressing the blood vessels, and this will reduce the blood supply into the uterine cavity, and also this will help in the contraction of the uterine musculature, which will reduce the amount of bleeding and in turn will reduce the complications of the sudden severe PPH which can happen. So there are two main compression sutures which are quite popular. One is the B-Lynch suture and the other one is the Hayman stitch. So I will first demonstrate the B-Lynch suture and I will show you on a live case how I have done it. And if still there are anything to be discussed on this practical aspect, then I will explain it to you. So this is the model of the uterus, which you can see here. And as you can see that this is the cut of the cesarean. So B-Lynch, as I have mentioned, this is a compression suture which will compress the upper segment of the uterus. So the first, here I have taken the needle, which is a straight needle. So here the first bite will go 3 centimeters below and 3 centimeters lateral from the uterine wall, and you just come out of the uterine cavity like this. So if you can see here, you have to come out in the upper segment. It is not very clear. Yeah, you have to come out in the upper segment. So here you go in and then come out through this. Then you go across the fundus, go posteriorly at the level of uterosacrals. So I will turn the uterus and show it to you. Across, at the level of uterosacrals, you just go ahead and come into the uterine cavity. So once you come into the uterine cavity, you just take it across. So you just take it across inside the uterine cavity, and from posterior to anterior, you come over the fundus, and at the same level where you have come in the anterior, just 4 centimeters medial to the lateral wall of the uterus and 3 centimeters. I'll just show you. So 3 centimeters below and medial to the lateral of the wall of the uterus. So this will complete the placement of the B-Lynch stitch. So these are all like brace stitches which will be across the fundus. So before you tie the knot, the assistant has to compress. So even before you attempt the B-Lynch or any kind of compression sutures, what you need to do is you need to first compress the uterus, check whether the uterine bleeding is under control, and then only attempt. So once your assistant puts pressure as much as possible over the fundus, then you can tie this knot after tightening it. So either you can suture this uterine the opening before this, but better you have to close it after you put the B-Lynch stitches, so that the cavity is seen clearly, and then while you come across from right to left, it is more visible. So right now I will show it to you as to how I have done it on the case. So this is the B-Lynch stitch. So here, as you can see, that I have exteriorized the uterus. I have taken a straight needle and I have taken this lower bite. 1 second, I'll just go back. So I have taken this lower bite here below the incision and I have come into the upper segment. And now I'm going across the fundus into the posterior wall. So here you can see that at the level of the uterosacrals, I'm going posterior to anterior and coming out in the uterine cavity. Yeah, so this is inside the uterine cavity where I'm coming out. You take out the suture and then you come across from the uterine cavity only. So you just go posterior again at the level of the opposite uterosacral. So come across the fundus again. And at the same level where you have taken the opposite bites, you go from upper segment to the lower segment. So once this brace suture placement is done, then you have to compress, the assistant has to compress the uterus with both the hands. And you can put the knot. So this was only for the demonstration purpose, which I have taken. Actually, there is no PPH here. So once you take out the clots from the uterine cavity, once proper compression is given, so this is how you need to tie the knot. And then you can close the uterine incision. And the suture which I have used here is the Vicryl number 12347 90 centimeters one. So the next suture is the Hayman suture. So here you don't need the uterine cavity to be open at all. So these are just simple brace sutures which are much simpler than the B-Lynch suture. So in this, the uterine cavity is closed. So this is mainly for the upper segment bleeding. So here you just take the bite anterior to posterior. You just take a bite and just bring it over and you tie the stitch here. So similar stitch, you can put it either 1 or 2 side by side so that it causes compression. So I will show you how I have put the Hayman stitch. So this is the demonstration of the Hayman stitch. Here you can see that the needle I'm straightening, the curved needle which is there with the 2347 number 190 centimeter Vicryl. I'm straightening the needle and the upper segment usually is a little thick. So you need to press it between your 2 fingers of your right hand, of your left hand when you take the stitch, and you come across the fundus and tie the stitch, tie the knot at the fundus. So you can hold it with the RT and then you take another bite.
Shilpa? Shilpa, madam? Dr. J, can you just check on her?
Yeah, I think she logged out.
No, she didn't.
Dr. Padmapriya, you continue till that time.
Just log her in. Just see whether she's asked for. Ask her, yeah. So practically let her come. Hayman stitch is, as she told, you go anterior to posterior and you tie it in the fundus. You can take 2 or 3 stitches so that, and ensure that it is getting compressed so that, the stitches don't go laterally. Basically, that's the whole point. When it goes laterally, it gets into the adnexa, and that's not good enough. And if you want, you can also place 2 more vertical sutures at the cervico-isthmic junction, so that even the, if you have a problem like in placenta previa or something, where you can take those sutures to ensure that even your lower segment is all right. So that's how Hayman suture is also done. I think, yeah, madam has come back.
Yeah, so this is the Hayman. I will start from the beginning. This is the demo. So here I'm straightening the needle of the number 2347, number 1 vicryl. So I will take the stitch just at the upper segment, maybe about 1 centimeter above the uterine incision. After I have straightened it, the straightening is only to make the length of that needle more, so that the bite comes anterior to posterior in one shot. Otherwise, we'll be struggling to pick it up from the posterior wall. So this I will hold it with the artery, and then a similar bite I will take one more across the other side, where again I press the uterine walls anterior to posterior with my left index and thumb. Then I will ask my assistant to pick it up from the posterior surface if I'm not able to do it. So here I'm able to do it. So in cases of atonic PPH, the problem is with taking these bites where the uterus is bulky and it is a little tough to do it. We will be struggling with the huge uterus and all. So here the contractility of the uterus is quite good. This is only for the demonstration purpose, which I have done, and there is no PPH in this case. So once you have both the sutures at the fundus, the knot has to be at the fundus. In case like if you want, you can ask your assistant to step on it and then take the knots. So the most important thing again here is the assistant has to compress the uterus as much as possible before you put the knot. So this is another stitch. So one of the so I'll show you the pictures where after putting and after, this was an actual case of PPH where I have put the Hayman stitch, and you can see that these are brace sutures where they sit tightly. And some people say that these can come out of the fundus and they will be hanging. So is there any problem? So I haven't had it in my experience. So in case if you want, you can take a bite at the fundus so that you can just anchor it there. It will prevent the falling off of the stitch. So this is another Hayman where I have put in between the one more stitch I have put, which is only to make sure that the bulge here, or if the width of this uterine fundus is quite more, then we can take multiple stitches like this. So one of the complications which the members had, one of the member in our group had posted, was the uterine necrosis. So this is the necrosis of the uterine incision area after the compression sutures which had been put. So here, once the compression sutures have been put, we should not try to strangulate and cut off the complete blood supply to the uterus, which can happen when we are doing combination of procedures. Say like we are doing the uterine artery ligation on both sides, then we do multiple sites uterine artery ligation on both sides, then you do utero-ovarian anastomosis suture, and then you go and put a compression suture. So these multiple things can cut off the blood supply completely to the uterus, which can cause uterine necrosis. And sometimes while you are doing the utero-ovarian ligation, so that time infundibulopelvic ligament also could be ligated by mistake or accidentally. So that time also the blood supply to the uterus will be cut off, and then you can expect these kind of complications. So I don't usually use the combination of stitches. I usually stick to either devascularization or the compression. So if I see that the uterus bulk is quite more, and if the atony is quite severe and there is upper segment bleeding which is quite significant, then I would prefer to do a Hayman stitch. Otherwise, if it is relaxing and contracting, then my first choice would be the uterine devascularization. So I will show you another this thing. So this is the opposition sutures, which is called cervico-isthmic opposition suture, which I'll be just demonstrating. There is no bleeding here from the lower segment. So this is mainly for the lower segment bleeding. You exteriorize the uterus. You ask either you ask your assistant to give traction, or you just pull the uterus to one of the sides. You take a bite in the lower segment after mobilizing the bladder. So the bladder should be mobilized at least 1 centimeter below wherever the stitch is being taken. You put your left hand, index and middle finger to the posterior wall so that you oppose that posterior wall. You push that posterior wall towards the anterior wall so that the bite taking is easier. When you take the bite, it is easier. So you just go back and then you come. Since it is a curved needle and the lower segment is quite thin, I have just come from anterior to anterior only, like after going posterior. So this will just oppose the anterior wall and the posterior wall. So this kind of stitches, you can put multiple stitches across the lower segment. So this will occlude the blood vessels supplying the lower segment. So similar to what I have done here on the left side of the patient, I'm doing it across like on the right side of the patient's uterus. So same way, you just try to oppose the anterior and posterior wall and take a transverse bite and take multiple knots. So these stitches can be done like, 3, 4, depending on how much is the bleeding and how wide is the lower segment. These, so I finish this presentation. Yes, Madam Padmapriya, I think we'll start with the questionnaire so that it becomes a little more interesting.
Oh, wonderful surgery, madam. I really liked it, and I liked your pelvis where you demonstrated it. And very important for people, if they are a little scared of uterine artery, internal artery ligation and all, they should know about these compression sutures. So between B-Lynch and Hayman, which one do you prefer?
So I feel on the patient doing B-Lynch is very cumbersome. I would prefer Hayman any day. And so that would be my first choice. I have done Hayman quite easily in many cases. Doing B-Lynch, like, taking those lower segment, coming out, again going across the fundus and then coming from posterior into the uterine cavity, that is the most difficult step in the B-Lynch. So I would prefer to do the Haymans if given a choice.
And how many have you done, so far? B-Lynch, Hayman, all put together, these compression sutures.
I think once in 3 months, I end up doing Haymans, especially, in these patients who are around 40s who conceive with IVF and who have this GDM, PIH. So somewhere, I think they will end up having this problem of uterine contractility. So to kind of deal with it, so I usually either end up doing the Hayman stitch or the uterine devascularization when they start bleeding. So if it is not managed with 1 dose of methergin and 1 dose of prostadine, and this is in addition to what prophylaxis we give of 10 units oxytocin direct IV at the 3rd stage of labor. If the bleeding is not controlled, or if I think the uterine contractility is not good, then I go ahead and either choose between the uterine artery devascularization or the compression sutures. And in the compression sutures, I would prefer to put the Hayman stitch.
Oh, wonderful. What about the reproductive outcome, pregnancy and further fertility following these compression sutures?
In my career where I have put the B-Lynch, I have followed up a few of my patients, around 4 or 5 of my patients, and none of them have had any problems. So the reproductive outcome has been quite good. I mean, I haven't faced any kind of problems with my patients.
Have you done any hysteroscopy following these compression sutures? Like if patients came with complaints of scanty flow and you have suspicion of synechia or anything?
No
Okay.
hysteroscopy.
So their menstrual cycle, has it been affected following these compression sutures?
No, ma'am. No changes in the menstruation, nothing at all. So I have done scans like after putting the B-Lynch or Hayman's, I have done ultrasound scans for them after a week and after 15 days. But there has been no significant finding which I can mention it at this point in time.
What about chose sutures? What do you think? And have you seen any patients, anybody's following that? Have you followed that patient up?
Yeah, chose suture. See, I have put chose suture, I think, in two patients, I think. And that was only when the placenta was slightly dipping into the lower uterine segment. I have cut through and through the placenta and delivered the baby. And then I have delivered the placenta. So in such cases where there is friability in the lower segment in the anterior wall and where there is bleeding, I have put the chose sutures. So I have had, I think, good control of bleeding, which is the most important thing. But I don't go around putting 10 or 12 of those. I put only about maximum like 4 in case if I feel that the lower segment is quite wide and I have to cover the area of the lower segment. Then I put maximum 4. But I have put 2 in one case and 4 in the other case. And they have had no problems at all.
No post-operative problem like pyometra or anything for them, nothing, right?
So somebody is asking chose 2 sutures on this dummy. So I will just show it. So this chose suture is nothing. It is just a simple thing, which is done, I mean, see, these are all, we should understand, these are all just opposition sutures, which you just oppose the anterior and posterior wall and compress them and cut off the vascularity, not completely, but cut off the vascularity. So here, what you're going to do in this, chose suture, you have to go anterior to posterior. See, you have come posteriorly here.
Yeah.
And then you go posterior, at least like say, same like 2 centimeters or 3 centimeters and come into the anterior wall. So once you come into that anterior wall, so you just tie this. That's all it is to chose suture. See, all these names look like, very fancy, but this is nothing but you are just opposing the anterior to the posterior wall. See, this is what you're doing. That's all. So this kind of stitches you can put at multiple places here, 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 here. So as long as you have dissected the bladder down, then this is quite a simple procedure.
Wonderful. And what is the time frame within which you should perform this procedure to prevent DIC from setting in?
See, it depends on the individual's tendency or the bleeding. If it is moderate PPH, then you have enough time to think and put and all that. If it is severe, massive PPH, then definitely you have to take the decision as quickly as possible. So I don't keep a time frame, but I keep the patient's pulse and blood pressure more as a parameter to start acting on it. So if, so I think that's the main thing. My anesthetist, if he is worried, then that's the first sign of worry for me. And that is when I start doing all the maneuvers and surgical methods which are required to control the bleeding.
Dr. Shilpa, hi, Dr. Sachin here. Can I just add a couple of points out here?
Yeah, sure.
Yeah, so Dr. Padmapriya, in answer to your question, the routine steps that we take after the removal of the placenta, we give methergine, or I've been using intramyometrial prostodin 125 micrograms since a lot of years, and that has ensured a good contractility. So at the time of C-section, 20 units oxytocin drip is on. Methergine is given for all RH positive patients and non-cardiac patients. And intramyometrial prostodin is given. After this, if you feel that the bleeding is much more than what is usual, and as we all know, the most important point to be noted in atonic PPH is that the feel of the uterus is going to be dovey. It's not going to get contracted. So we give a nice bimanual massage to the uterus along with all these maneuvers. And my maximum wait time is 3 to 4 minutes, not more than 5 minutes. In this much time, after doing everything, you feel that the uterus is not contracted. The bleeding is much more than what is usually expected. We just did one at Jai's place last week. It was a IVF section that we did, and in 5 minutes there was severe atonic PPH, and in 3 minutes it takes us to do the B-Lynch sutures. Now, as regards the multiple compression sutures, I would recommend just one thing. Since 2001, we've been doing B-Lynch sutures. We started first at Sion Hospital after reading Christopher B-Lynch's article. And trust me, yes, as Dr. Shilpa rightfully said, it is a bit complicated. But as she has shown in a dummy and in patient, what I would suggest is do it a few times, and then it just becomes reflex. And what is the advantage of B-Lynch is, since it goes above the uterus and also at the lower segment, while you're tightening the sutures, I'll tell Jay to share the video on the groups. While you're tightening the sutures, it is the assistant's job to compress the uterus completely. Since the uterus is going to be very soft, it's going to be very easy to compress. So a normal size uterus will become half of it, and only after that you will tighten that. And in almost all the cases, we've never had to proceed with either internal iliac or with obstetric hysterectomy, and B-Lynch has saved the day.
Thank you, sir. Thank you. That was a good input. Dr. Shilpa, what is the Shilpa?
Yeah.
What is the prophylactic, any prophylactic use for these compression sutures, doctor?
No, ma'am. I mean, I do it only as the treatment of PPH. I don't do it as prophylaxis at all. I mean, only when and as and when required, I'll do these kind of procedures. Otherwise, I usually don't do it at all.
Okay, ma'am. And how do you follow up these patients, madam?
No, usually anyway, my post-op follow-up after cesarean is like 1 week to 10 days after the cesarean. And then after that, after 60 days. So the same routine I follow unless they come with repeated fever, or they come with pain abdomen, or they come with pus discharge in the vagina, like foul-smelling lochia. Only then, I mean, if they call, then I ask them to come. Otherwise, I haven't had to see any of my patients who have had compression sutures come with any kind of complications.
Okay, madam. And last thing, have you delivered patients after that, following this?
Yeah. So I have delivered patients with after putting the B-Lynch, and see, usually we make a note and we kind of highlight it on the front page saying that the patient had PPH in the previous pregnancy. So we are all cautious when this patient comes in labor. We keep everything ready. We have a PPH kit which has everything. It has 2 cannula, wide bore cannulas. It has the blood set. It has methergin. It has prostadine. Prostadine as in like it has to be stored in the freezer, but this we mention it there and we make sure that it is there. So, and misoprostol tablets, so everything is available in that kit. So we keep those kits ready in case if the patient who has a previous PPH, if they come in labor, we kind of are very alert to deal with PPH, because I have had patients, like I think 3 patients who have had repeat PPH in the subsequent pregnancies also, but we were prepared, and we were able to control the bleeding with medical management only, without having to go into any kind of surgical maneuvers. Even I think we should talk about Bakri balloon.
Bakri balloon. Yeah, role of Bakri balloon. That's my last question. Yeah.
So Bakri balloon I use mainly in cases of vaginal delivery who end up having PPH. So before I go ahead and open the abdomen to do either devascularization or to do the compression sutures, I prefer to use the Bakri balloon. Bakri balloon is a fantastic, I think, innovation which come in, and I think this balloon should be in every labor room, and this has been a lifesaver for me in many of my patients, where I have put the balloon, inflated it with 150 ml of normal saline, and we remove it after, say, like 8 hours, 10 hours, 12 hours, or even 24 hours after putting it. So this has been a very good, I think, a replacement before, or I think before we take a decision to do a laparotomy, I think Bakri balloon, especially in vaginal delivery cases, is quite useful.
Yeah, madam. I'll take the questions from the chat box. Role of carbitocin. They have asked.
Carbitocin, I use, see, either syntocinon or carbitocin, either one of them I use as prophylaxis. So nowadays we are using carbitocin routinely as prophylaxis after the delivery of the baby. So I use 1 ampule IV slowly.
I think we pretty much covered everything. Wonderful, madam. With your experience, I mean, I think it made it a very, very good topic of discussion and presentation.
Yeah. So, madam, I think, see, because I'm a single consultant unit. So what is your experience, since you are in a referral unit with so much of other good backup specialities like blood bank and the other ICU?
Intervention radiology. We have intervention radiology.
Yeah. So what is your experience?
We select the cases accordingly, madam. Basically, we have cases which are referred from smaller nearby standalone birthing units. So same thing, vaginal deliveries, by the time they take a long time. By the time they send, some of them DIC is already set in, and some of them. So yeah, compression sutures, I think they would have tried it in their clinic, failed and sent, or if we face it, because if they've referred and we are facing it on table, same thing, what you follow compression sutures. I prefer, B-Lynch is really good for me because I've gotten a hang of it. And of course, if I have to just quickly finish it, Hayman's, if I don't feel there's massive PPH or anything. Bakri is something that I personally love, even for cesarean or for vaginal. That will be my first choice always. And it has, once I started using Bakri, I hardly have to put all these compression sutures. And of course, we have a very good IR team. So intervention radiology. So they're always there. Yeah.
Yeah. Thank you, ma'am. Thank you. That was wonderful.
Thank you
Hey, why should we not do internal iliac, madam, in all these cases? Just asking.
Sir, tomorrow you tell us, sir, please. Okay. Thank you, sir. Tomorrow anyway, the
really?
class is on internal iliac, sir. You tell us, sir, why we are not. See, I think more than anything else to answer your question, see, internal iliac needs the retroperitoneal approach and opening that peritoneum and doing it when we are already like having we ourselves will have tachycardia, and I think we'll be hyperventilating, and our saturation only will be down once we come across PPH. So I think like our training is not as good as we want it to be, especially in cases where the retroperitoneum has to be approached. And so internal iliac, we don't consider it as the first option as a hardcore obstetric trained people. So I think since you are more well versed in retroperitoneum, and it is like, even you can close your eyes and tie the internal iliac artery, I think. So that kind of ease and confidence we don't have. So that's the only reason. Otherwise, if we know, then I think that would be like, a game changer in every obstetrician's practice. And I hope you can bring about that change and be that game changer in every obstetrician's life.
No, the reason why I'm asking this question is because if you go and tie the internal iliac, okay, then it is way more better in controlling the atonic PPH, okay, short term, long term, medium term, all the three complications, immediate, 2-hourly, 8-hourly, okay, as
Agreed,
far
sir.
as atonic PPH is concerned, okay, because you really virtually don't really require medical management to act immediately once internal iliac is done. And if there is a standardized approach, then I think it is far more superior than probably compression sutures. This is my experience. So I
No,
just thought I'd get.
completely agree, sir. But see, we are looking at obstetricians
What
who are
everybody
working
can
in
do.
remote areas. We are looking at obstetricians who are single-handedly running government hospitals, doing like 3-digit deliveries single-handedly with very minimal backup from anesthetist and other specialties. So for them, like their training will be more with regard to the devascularization and also with the compression suture, even by them. I mean, even for me and Dr. Padmapriya, I think like, we are very comfortable doing it, and we can finish it in like, say, maximum like 3 to 4 minutes. That is max. Usually we finish it in like less than 2 minutes. So that is the kind of the action that is required at that point in time. And for internal iliac, if we struggle for 20 minutes to 25 minutes to locate the internal iliac, that anterior division or even that whole internal iliac, and get confused in the end and start turning pages or start looking in the mobile for the photo, oh, how that external iliac goes towards the pelvic wall, how that internal iliac dips into the pelvis and all those things. I mean, I don't think our brain will be like, super sharp at that time. So what we do, it is at the spinal level reflex, which comes especially when a woman is bleeding. So I have had 2 deaths of PPH. So the first one was, I think, within the first year of my practice. And it was like, I think, one of the most horrible experiences of my life. And I can empathize, relate to all the obstetricians who have gone through a case of PPH. I mean, it is one of the most terrible thing any obstetrician can face.
I must say, madam, honestly, this has been a very honest and very good session on compression sutures, and your points and your opinion well taken. True from the heart.
Thank you, sir. Thank you so much for joining. I mean, we owe you for your time that you spent with us, almost like 40 minutes of your 120 hours in a week that you work. Thank you so much, sir. So,
thank you. Thank you.
Padmapriya.
Thank you. Great session, madam. Impressed.
Yeah, thank you. Thank you.